Good afternoon and welcome to the Insurance and Pharmaceuticals Subcommittee of the House Health and Government Operations Committee. This is the committee where we have two bills to work with today that are still in sort of a working posture. Want to work out a couple of things on both bills. I'm hopeful that we can perhaps move at least one of them because we've moved something down. We've moved it down the line a little bit. I don't know if is Senator Lamb here. Chris, you're here for Senator Lamb.
Yes, Chair. Thank you. Chris Daniel for the record, Senator Lamb's Legislative Director.
Okay, can you stick around for a while and I can do the other bill first? Okay, if it's the senator, I was going to take him. Sorry, Chris, I don't mean to be disrespectful, but I want to.
No problem at all.
I've got a lot of people on 1274 here. So the first bill we will take is House Bill 1274, and this is prescription drugs, pharmacy benefit managers, federal 340B program. Lisa, want to tell us what it does and about the amendments that we've brought forward to the committee?
Sure. So House Bill 1274 establishes requirements and prohibitions on a pharmacy benefits manager relating to coverage and reimbursement of prescription drugs purchased under the federal 340B drug pricing program. There were amendments that were distributed that strike the term purchaser throughout the bill. They also strike provisions regarding mail order, profit sharing, reversing and resubmitting claims, billing modifiers, and adopting regulations.
Okay. And then in addition, we got some feedback from some of the pharmacists. And what I would like to do is I hope that you have your reprint in front of you, is to go through the reprint and see if there are any issues with any of the amendments. That first we'll do the amendments that we brought to the group, and then we'll do the amendments that the stakeholders have brought to the group. So we're going to start on page one of the first page of the bill, and the first change is lines 21 to 24, which is requiring signature from the beneficiary. It's all struck out. That's the person getting the benefit to say that they would accept mail order. So that part would be gone. Any problems with that? Please raise your virtual hand if you have a problem with it. Okay, seeing no one. I'm not going to ask about the purchaser piece because I think that everyone understands that is related to the definitions that we are still working with under the last year's 601 bill. And so the next major change is on page 204 of the reprint, and that's lines 19 to 21. And it basically says that a PBM cannot refuse to allow pharmacy in their network on the sole basis that they participate in a 340B program. Any issues with that? Okay, seeing no one. The PBM can't, we took out the language that they can't charge more than fair market value. They can't require as a condition of coverage that the beneficiary participate in the 340B program or coerce a beneficiary into specific mail order programs. Any issues with the strikeouts in 22 to 29?
I don't know if you can hear me. I apologize.
Yes.
How do you raise the hand? Is it under reactions? Or...
Yeah, it's under reactions.
Okay.
Okay, but you can go ahead now. You can go ahead now, Steve.
Okay. So there's no opposition. Those clauses that were put in, the previous one and this, are because these things have happened to pharmacies either in Maryland or across the country. So in the spirit of bipartisanship and moving things along, they certainly can be stricken, but they weren't put in there arbitrarily. They were put in there because they've occurred in the specialty space or in spaces. Pharmacies have experienced that. So, but let's move forward.
Okay. On lines 30 to 31, they can't impose a different reimbursement or network participation for pharmacies that participate in 340Bs. Any problems with that? Okay. Looking at page 3 of 4, require a pharmacy that all struck out that would reimburse or resubmit based on some notification or clarity around 340B claims. That's 3 through 7. Any problem with that? And then the strikeouts in 8 through 11, requiring a billing modifier is all struck out. Any problems with that? Okay. And then on the bottom of page 3 of 4, 28 to 32, striking out that the claim is final at the point of adjudication, which I think this just brings us back into what the normal process is. And the striking out that administration would adopt regulations. So, Steve.
Yeah, there has to be some sort of oversight clause to make the bill have any teeth. From experience, if the MIA has no recourse, if these things occur, what good is the bill? So there should be some recourse for noncompliance.
Okay, I'm going to go to David Cooney from MIA to respond to that.
All right, thank you, Delegate, and thank you, Steve. And I might defer to Van Dorsey if he needs our Chief Counsel if I speak anything incorrectly here. But we do not believe that is necessary. I mean, even if it's not specifically in this section of the law, once these other requirements are codified, we have full authority to enforce this. The PBM subtitle even gives us specific authority, which is not even necessary to promulgate regulations. We have general authority already to do that. And the PBM subtitle already gives us authority to promulgate regulations to implement anything in subtitle 16. So even if that language is not there, we would still have authority to enforce these new requirements.
Is that adequate, Steve?
Absolutely.
Okay, thank you. I'm going to ask, is Kathleen Longren on the line? Kathleen? Okay, we're going to, hopefully she'll get back to me. So then I wanted to go over, so we're okay with the amendments that we brought to you before. Now let's go over the amendments that came from, actually from Steve Weiner. And I am looking at the first page where he has suggested adding the definition of covered entity. Steve, you want to tell us why that's important?
Yeah, just like the term 340B program has a federally qualified or federally identified definition, covered entity is also federally defined and identified under the same Veterans Act that identified the 340B program. On page 3, lines 17 to 21, there is a mention of prohibit an entity authorized. And it just is a cleaner, more defined way. We are talking about federally defined covered entities. And the nomenclature makes sense to make it coincide. I don't think it shouldn't be confrontational, but that's why it's there.
Oh, thank you, Steve. So questions about this? Kimberly Robinson.
I was just going to say, I think it's fine. I think it makes sense. I think it's just quite fine.
Okay.
The bill didn't use the term. I thought about adding it. I went with the term that was in the bill when I offered amendments. So I respect what Steve is doing.
Okay. So the next thing that Steve was recommending was the new number 3, which is pharmacies participating in 340B means a pharmacy owned or operated or covered by a covered entity. Steve, is this just an extension of clarifying?
It is. Now, it's not necessarily federally codified like the other two, but you're talking about two pharmacies. One's where the nonprofit covered entity owns the pharmacy, and you're talking about ones where the nonprofit covered entity or Ryan White program has a contract with a covered entity. And those are industry standards. Again, the definition was not meant to cause problems.
Any concerns from anyone with this language? Okay. And then on the bottom of page 2, below line 31, there's a change, Steve's recommendation that the network pharmacists that participate in a PBM network based on whether a pharmacy or pharmacist participates in 340B cannot impose any fees, chargebacks, clawbacks, adjustments, costs, or other assessments on pharmacies or pharmacists participating in the 340B that differ from other pharmacy practices.
So the first part of that, network based on whether, that actually was just brought from the following page, just so it would make sense. So that's not a change. The change was you talked about in the amendments that were originally presented, not giving special benefits to 340B contracted pharmacies and not changing, rewarding them. And this just takes that same vein with respect to punishment. So the clause above it says reimbursement or network participation. This just goes one step further and says, okay, no extra fees for these pharmacies. And again, the last sentence of it is clear. It's on the basis that the pharmacy or pharmacist participates in the 340B program. So it's not to gain more, it's just not to be punished more because of that.
Okay, questions or concerns about this piece? Kim.
Thank you again, Delegate Collison. I think I might be okay with this. I will admit I was very tied up on another bill yesterday, and I missed when Lisa sent the subsequent email, so I didn't see it until shortly before today's subcommittee when I was pulling up all of the documents. So I haven't had an opportunity to talk to any of the experts inside of the company. I think that Steve did a good job drafting this to keep it at a parity positioning as he described it. So I think I would be okay with it. I can't say 100%. I wouldn't come back with pushback once my person looks at it, but I think he did a good job meeting the goal he described of trying to make it so that it wasn't more or less favorable based on the status of the pharmacy, different than if it was about, say, a claim where there might be a reason why a claim needed to be adjusted because of it being 340B for specific reasons. I think he did a good job with the drafting. So I've sent it over. I'm hoping that Katie will get back to me really, really quickly, maybe even before you're off. So if I have to go screaming that my hair is on fire, but I don't think that's gonna happen.
Okay. So we'll hope she'll get back to you, but and then I think the last change is on page 3 of 4. It's a new E. This is about the regulations, and we've said we don't need that. Okay.
Correct. And then 17 through 21 just changes entity to covered entity to coincide with the proper definition.
Okay. We're going to give the folks that Kim has looking at this now, and I'm going to ask again if Kathleen Longren is here or anyone representing an MCO, because I understand there might be some issues with that, but seeing none, it may be just really as it relates to 355. So we're going to give you a couple more minutes, Kim, to get a response and move on to, but what I'm hearing is general consensus on 1274, barring any issues raised by the language on the bottom of page 3, 2. Okay. So let's go to Senate Bill 355. Lisa, what's this bill do? It's HIV preventive drugs insurance requirements.
Senate Bill 355 requires Medicaid to provide medically appropriate drugs approved by the FDA for HIV prevention, including PrEP and PEP. The bill also prohibits carriers and MCOs from requiring prior authorization or step therapy for PrEP and PEP for HIV prevention and impose any cost sharing required. There are amendments that Senator Lamb has proposed that strike the provisions of the bill that would have authorized a licensed pharmacist to prescribe and dispense PrEP or PEP.
Okay. Just see her. Let's see it. So now, Chris, if I can ask you, Chris Daniels, if I can ask you to talk a little bit about the bill and how it came to be in this position.
Yes, thank you, Madam Chair, members of the committee. Chris Daniel, for the record, Legislative Director for Senator Clarence Lamb, here on behalf of the Senator to discuss SB 355. This is an amended version of a bill that we drafted last year, and over the course of interim discussions, had tried to, affirm the pharmaceutical pathway for the distribution of these therapeutics. And despite the unanimity in the Senate, we had to unfortunately cut the pharmacy parts out here when we got to the House because it was not the intention of our office to put forth a bill that did not have the appropriate, consensus from the pharmacy. There was still significant pushback and concerns raised by MedChi amongst the pharmacists. And so while we believe that the two components of this bill, that which is the pharmaceutical pathway, as well as the provisions that relate to cost share, are both very important access points to kind of address some of the alarming levels of HIV that we see here in Maryland, we feel that even with just the cost sharing portion of this, that this would still be a very significant step forward.
Okay, thank you. Questions, comments from the committee members on this amended bill? Matt Celentano.
Thank you, Madam Chair. Thank you to members of the committee giving me an opportunity to talk about this bill. The carriers are confused on this bill a little bit. So the post-exposure portion of the bill, the carriers were neutral on, and Delegate Kelly's bill has already passed. And there is no cost sharing for the PrEP drugs because of CDC and federal preventive services. So that portion doesn't really matter. And the 8 services that are laid out by the bill are already covered at no cost share by the carriers. All 8 of them is laid out in the bill. So the only thing that really remains, and then the pharmacy portion is out of it now, which is the only access portion of the bill. So the only thing that is really left in the bill for anybody to take a sort of position on is the prohibition of prior auth in the pre-exposure drugs. There are only 2 drugs really in this space, Truvada and Descovy. If you look at the CDC recommendations, Truvada is recommended for everyone. Descovy is not recommended by the CDC for all populations. So it is very critical to make sure that the patient gets the right drug by retaining the prior auth for the carriers. In the San Francisco AIDS Foundation report on PrEP drugs, you will see there's a discussion of the 2 drugs. And for Truvada, it's shown to be effective for everyone, including gay and bisexual cis men, trans women, trans men, heterosexuals, cis women, people who inject drugs. For Descovy, it is only recommended for gay and bisexual cis men and trans women. And they note there is no clinical data to support use in people who may be exposed to HIV through injection, drug use, or vaginal sex. So we think that the prior auth is appropriate to remain to make sure that all populations are steered to the drug that has the most medical effectiveness and doesn't create side effects that might be problematic. So we respectfully ask you to retain the prior auth portion for pre-exposure populations.
Thank you, Matt. Scott Tiffin.
Thank you, Madam Chair. I'm here on behalf of the Maryland Nurses Association and midwives, as well as healthcare for the homeless. You know, Matt is correct that, you know, the clinical indications for Truvada and Descovy are different, but the providers that we work with don't necessarily feel that prior auth is what needs to happen in order to figure out what is the most appropriate drug for a patient. We think the provider is actually the ideal person to figure out which clinical indication is appropriate. You know, the other thing that we just want to flag, you know, especially for healthcare for the homeless, when we're working with folks who are extremely marginalized by the healthcare system, who are at extremely high risk of HIV, even slight delays, even 24-hour delays can really compromise their health. And so that's where we see the prior auth as being a burden for folks and getting hooked up with PrEP as soon as possible, getting protection as soon as possible, and keeping them safe. So I just want to throw that out there.
Okay, thank you, Scott. I'm going to go to Delegate Kelly and then I'll go back to Matt. Delegate Kelly.
Thanks. I just wanted, I think, a little bit of clarification because Matt mentioned my bill, which is very small as compared to this bill and is just sitting in finance and hasn't moved, I think, because we're hoping or expecting to do something with this bill, which is fine. I don't need my bill to pass, but I do think that this is an important issue to be addressing. But I guess my question had to do with sort of the Truvada Descovy sort of situation. I'm going to assume that Descovy is much more expensive than Truvada. So is there a price difference? And also, do you see clinicians, like, do you have experience with clinicians prescribing one over the other when it's not clinically appropriate, and then sort of utilizing the prior auth as a way to get clinicians down the right path, based on what Scott just said of, like, let's trust the clinicians to know what they should be prescribing?
Thank you very much for the question, Delegate Kelly. That is a secondary concern. The first concern is to make sure that the drug goes to the appropriate where the population, and Truvada is approved for everyone and Descovy is not. The secondary concern is that Truvada is about $300 a year. Descovy is about $23,000 a year. And as you might imagine, the pharmaceutical interests the manufacturers have a lot of interest in making sure that Descovy is at the front of the provider's brain. And because they're busy and they're being marketed to all the time, we feel that an extra level of protection for healthcare costs is appropriate after we talk about the medical necessity side. And that's why prior auth is a good tool to make sure that not only are we getting the right drugs to the patient, but that we do consider the price implications.
But so I'm not sure if I heard in your answer, are there, Scott just said, hey, let's trust the clinicians to be prescribing the right one.
Right.
Are there situations where a clinician is prescribing Descovy and you guys are coming back and say, try again, let's go with Truvada?
Absolutely. But there's also instances where the doctor might say, I know this population and this reason, I'm filling out a quick form checkbox that could be instantaneous. This patient needs Descovy, and then the carrier prescribes the Descovy. So it's not, the price implication is a secondary concern to the person getting the right drug.
Thank you.
Thank you, Delegate. Deb Rifkin.
Yeah, just to, Matt did a great job explaining that. We absolutely do not pre-auth all PrEP drugs, right? So Truvada, the generic Truvada there is no pre-auth. So there are the appropriate drugs that apply to all populations. There is no pre-auth. Pre-auth is only on some of the drugs because there's a necessity for that, which again for Descovy is because it's not for all populations. And we, in fact, based on your question, we did see with the pre-auth that we have when the generic Truvada was approved, we now have seen the change from Descovy to generic Truvada. So it has made a difference through the pre-auth that they recognize that there's a better alternative than Descovy for patients. And we have seen that because of the pre-auth. So it has made a difference.
Okay. Delegate Kelly, you're looking, your hand is still up and you're looking puzzled.
Oh, I'm sorry. My hand should
okay?
be down though. My question was answered. Thank you.
Okay. Kim Robinson.
Thank you, Delegate Collison. So not to repeat what you've already heard from Deb and from Ms. Rifkin and from Mr. Celentano, but just to add to that, I think that there's, this sort of historic tension between providers and carriers when it comes to pre-auth. I think it's also important to remember that, one of the benefits of pre-auth, especially under Maryland's law, is that once we approve it, it's covered and you don't ever have to worry that it's going to be reviewed after. But the way insurance typically works is things that are covered, those claims are reviewed. And so if something is not provided in line with the clinical guidance, there's a chance that now that claim becomes in dispute. And so that's something we don't want to see when there's certainly this guidance that's out there. I've learned a lot about pre-auth in my time at Cigna and how it works and why it's used and how our guidelines are updated, and they're updated on a very frequent basis, especially as the science is changing. There's a great quote from a physician, an oncologist, who talked about how quickly people are learning about drugs and how the science is changing, and that the time, how quickly things evolve. They say we learn something new every 73 days. It used to be, 3 years was how long it took before we really learned new things. And so what we do is that we are staying up to date with the guidance. Should Descovy become appropriate for a broader audience, things will change. But right now, because there's those limitations, we do find that, to Delegate Kelly's question, it does find providers who sometimes are who are prescribing it when it's inappropriate. Certainly not every provider, but that matters for the patient because you want the patient to get the most effective drug. And this is distinguishable from Delegate Kelly's bill that was focused on the post-exposure. In this case, we're talking about the pre-exposure, whereas the reason why you did not have carriers opposed to Delegate Kelly's bill is because of not only getting the right drug to the right person, but knowing that there's a time sensitivity with the post-exposure. So we're talking about two different things under the bill, and we think that's also important not to lose sight of about why, her bill is very important in its own right.
Okay. So I'm going to take, I've got, I think, 4 more questions. We're going to take the 4 more questions, and then we're going to go back to 1274, see if we can vote on 1274. As I said, SB 355 will come back to us next time, but we'll have this information. Lisa Jordan.
Thank you, Madam Chair, members of the subcommittee. It's a pleasure to be here. I'm Lisa Jordan with Maryland Coalition Against Sexual Assault. I did want to just echo a little bit the statements of my colleague, Mr. Tiffin, and bring just the issues of people who are engaging in sex trafficking into the discussion, because for people who are engaging in sex trafficking, it is extremely important to have access to PrEP. And although it's easy to say that, pre-authorization is, something that we all can deal with, that is extremely difficult if you are working on the street, if you're homeless, as Scott's population is. And the idea that we need to have another layer in addition to the healthcare provider for this population is really something that could produce a barrier to care. So for the PrEP piece of the bill, I would just ask the committee, think about that population. Of course, for rape survivors, the post-exposure piece and Delegate Kelly's bill is extremely important. And so we are somewhat concerned that it is day 12 or 13, and I don't want to see one bill lost because we're talking about this bill. So would just hope that we can act quickly enough that we can at least address the post-exposure, even if we have to come back another day on the pre-exposure. Thank you.
Okay, thank you. Steve Weiner?
Yeah, just a few comments. In terms of Descovy and Truvada, they're widely seen to be equally effective in all populations. I understand there might be some indication issues. A lot of it has to do with the time that the drugs have been on the market. The big difference between the two is Descovy is more harmful to the kidney than Truvada. That's the big difference between the two. For patients that have a kidney issue, they should not be on Truvada. Patients have the potential to have kidney issues, should be prescribed Descovy. So it's a safer drug for the kidney. That's the difference between the two. In terms of pre-auth, again, I'm a drug expert. From a pre-auth can take 72 hours. So just keep that in mind. It would be nice if it has to have it, maybe have some way to streamline that in 24 hours instead of 72. 72 is a long time for the populations we discussed. So I just wanted to make those comments. EPIC supports the bill, obviously. Thank you.
Thank you, Steve. Allison Taylor.
Hey, thank you, Madam Chair. One quick comment. So one use of PrEP that hasn't been mentioned is that it can be taken by HIV positive pregnant women to prevent the transmission of HIV to their babies. And so it would be taken by the woman and then taken by the baby shortly after birth. So as the bill was initially introduced, we had objected to the pharmacist prescribing for one reason being, we certainly think mothers under this scenario should be under the care of a physician, but I think that same concern applies in this prior auth situation too, as Mr. Weiner just mentioned. A difference in whether someone has a kidney problem or whatever. We want to make sure that pregnant women and their little babies are as safe as possible. So we think the prior auth requirement is appropriate.
Thank you, Allison. Jen Bremen.
Hi, Delegate Collison. Thanks for the opportunity to comment today. And I'm sorry that I'm joining by phone, so I apologize if it breaks up at any point. The MCOs respectfully
Jen, you just broke up. Jen, you're going to have to find a spot where you can sit for a minute because we need to hear what you're saying, although we are going to discuss this bill again. We're not hearing you, Jen. Okay. We are going to discuss it again, and please get in touch with me. Either you or Kathleen get in touch with me and let me know what the concerns are. I'm going to go to Deb Rifkin, and then we'll close out with Chris Daniel on this bill, and we will do a final conversation on 1274. Deb.
Thank you. So I just wanted, I heard what Steve said, but from a carrier's point of view, we look at national guidelines, and the FDA has not approved Descovy for all patients. And we do not feel it's appropriate for us to ignore what the FDA or the CDC has stated. So if and when that changes, we change our guidelines. But until that time, carriers believe it's appropriate based on those national guidelines that the FDA has specifically stated that it is not appropriate for all populations, and therefore that's why there is the pre-auth. The other thing I'd like to say is that we have a law in the state of Maryland for prescription drug electronic pre-auths that says if you need a pre-auth for a drug and you go online, as any provider has the ability to do, and the provider has to do, there is basically a check-off. You check off the different things for the drug. If you meet all the criteria, it's auto-adjudicated. It's immediate. It's real-time approval. So that's the goal of the real-time law that you all passed. If there is any differentiation or you need additional information, there's different time frames. But if you check off the boxes as so it's therefore truly indicated for that patient, you will get the drug right away.
So
there should
Debbie,
not be a wait time.
I think, thank you for that. And I guess I want to just confirm what I think I heard, which is that there is no pre-authorization for Truvada and its generic. Is that correct?
That's correct. That's correct. You just prescribe it.
Right. And it applies, and it is suitable for all populations.
Correct.
So the issue of folks that I know Lisa was talking about who may not be insured, that Truvada would be available to them just by going to see their their provider at that moment. So, okay, I just want to make sure of that. All right, Chris, you're going to close us out on this bill for today.
Yes, thank you, Madam Chair. And I'll be very quick here. I just want to say one more thing about that wasn't discussed earlier is that prior auth, even when streamlined, if everything goes right, so if there's an issue with a provider who might be, super busy in an office and the pre-auth and they check the wrong box or something to that effect, we're looking at, a delay that increases the chances that the drug doesn't take effect in a timely manner. One other thing I wanted to mention is, and I appreciate the consideration of everybody's opinions here on the committee, and I want to just call out Matt specifically and thank him. I know the committee has been very much in with LAM bills this year, and I want to make it clear that the late minute amendment was not meant, the posture that it's in now was not at the result of no negotiations or no discussion. Matt has been very kind in speaking with me, and this was not meant to be an 11th hour attack here on the bill, but truly not wanting to put forth a pharmacy provision that was inappropriate, that could be inappropriately administered. So with that, I just want to thank the committee, and I respectfully urge some consideration on this bill.
Thank you very much, and thanks for stepping in and pitch hitting for Senator Lamb. All right, we are, as I said, this bill will come back to us in our next meeting. And Kimberly Robinson, do you have any good news for me?
Actually, I do. There is so my only request is it would be just a slight cleanup to the language. It would really say the same thing. North Carolina has a provision similar to the one that Dr. Wiener put forward. It might even be where he found it, and other things written about it. I'm happy to copy him on an email to Lisa with the specific way North Carolina wrote it, which I think just fits a little bit more neatly in the bill, but I can read it to you if you would, care
Please.
to hear it. It says, hold on, because I have to open another window. It's actually, maybe it might be actually his same language. Actually might be this, well, yeah, I think it might even be the same language. So maybe he copied it from North Carolina directly. So
we're good to go?
I think we're good to go.
Okay, can I have a motion on the amendments on 1274?
So moved.
Second.
I moved by Delegate Kerr, and I heard a couple of seconds. Any discussion on the amendments? Matt Celentano?
No, sorry.
Oh, okay. Any discussion on the amendments? Seeing none, those in favor of the amendments, please say aye. Those opposed, please raise your virtual hands. Only committee members, please. Yeah, right, Matt. Okay, seeing no hands other than Matt's, and he doesn't count. The amendments have passed. Can I have a motion on the bill as amended?
Move the bill as
amended.
Second.
Okay, thank you. We have a motion and second. Any discussion on the bill as amended? Seeing none, those in favor, please say aye. Those opposed, raise that virtual hand. Not seeing anyone. The motion passes unanimously. Thank you all very much. We're gonna get ready to walk over to the floor. I really appreciate your time. Please watch the website to see when we will have a chance to meet again. Alrighty, with that, thank you.